everyone. As people are still joining in, I just want to welcome who is here so far. Welcome to Reclaiming Language Access in U.S. Latino Communities, Patient-Centeredness at Risk. Thank you all for joining us for this conversation. Before we get started, we want to get an idea of who's here with us. So if you can, take a minute to answer our poll, letting us know what you do. The common occupations we anticipated are university teaching, research and administration, undergraduate or graduate student, K-12 education, community organizing, and public health and healthcare. So if none of that covers what you do, go ahead and choose other. And while we're waiting on everyone's responses and just getting started here, please take a moment to familiarize yourselves with the webinar platform. See your Q&A tab on the bottom of your screen or on the top of your screen if you're using a tablet. You can type and send your questions in at any point. We'll be monitoring our Q&A throughout the webinar so we can address your questions during our discussion at the end. We want to hear from you, so as questions come up, please feel free to send them our way. You can also upvote questions, which means if you see a question that you also want answered that was asked by somebody else, you can go ahead and click that thumbs up button, and that will upvote the question, and our moderator will see that at the top of their screen. If anyone is having any technical difficulties, go ahead and contact the number on the screen right now. That's 614-247-2048. Again, that's 614-247-2048. So please only call this number for assistance during this webinar. That's when it's available for. So it looks like we still have some responses coming in for our poll, so I'll give you another second to get that completed. Okay, I think we probably have enough responses here. It looks like the attendees have started to kind of even off. So let's see the results of our poll. So it looks like we have predominantly university teachers, researchers, administrators, but we also have some students here, some community organizers, public health, healthcare. 15 of you are other, so I'm interested to see who else we have when we look at the registrant list. We are so glad to have everyone here. We've been really looking forward to this conversation, so thank you for being here. Our panelists today are going to discuss some of the ways that language researchers can engage in patient-centered outcomes research, ultimately aiming to stimulate dialogue about what patient-centeredness can look like for U.S. Latino populations. Our panelists are also going to highlight the urgent need for this kind of research now by offering context on how Latinos in the U.S. are experiencing COVID-19. Our team includes researchers and teachers from throughout the country, including Perizad Deshboard Sawan from the University of Akron, Dalia Magana from the University of California at Merced, Rachel Shosak from Wichita State University, and Carol Hardin from Baylor University. Maricel Santos from San Francisco State University will guide our Q&A session at the end. Glenn Martinez from The Ohio State University and Carmen San Martin from the University of Texas at San Antonio will start us off with a brief introduction. And Glenn will take it to our panelists from there. Glenn?
Thank you so much, Tatiana, and thank you everyone for joining in this conversation. We're going to have plenty of time for Q&A at the end, so please stick around for that. We want to hear your thoughts and opinions. So the COVID-19 public health crisis has really exposed and exacerbated many of the known deficiencies in the U.S. health delivery systems. We think about weaknesses in supply chains for PPE and medical equipment, shortages of healthcare professionals and hospital beds, inequitable distribution of resources driven by competitive bidding processes. All of these things have had the cumulative effect of debilitating the system's ability to respond effectively to COVID-19. The consequences of the pandemic, however, are also highlighting enduring racial and ethnic disparities. From New York City to New Orleans, and in meatpacking and critical food supply chain industries throughout the rural United States, What we're seeing is that the case fatality rate of African Americans and Latinos is outpacing that of other racial and ethnic groups. In New York City, for example, Latinos account for a disproportionate share, about a third at last count, of all mortalities with known race and ethnicity. The uneven impact of COVID-19 on Latino populations throughout the United States is evident not only in an increased likelihood of succumbing to the virus, but also in the social and economic spillover effects of the crisis. Latinos, for example, have been shown to be the hardest hit by pay cuts and job losses, and are also more likely to view the crisis as a major threat to their personal health, financial situation, and day-to-day life in their local communities. These disparities, we know, are driven by multiple intersecting factors that include overrepresentation in essential service sectors, inability to effectively follow social distancing guidelines, and inadequate access to vital public health information. Access to health information has been an intractable determinant of health disparities in Latino communities for decades. Limited English proficiency and low health literacy have been identified as key determinants of inadequate access to health information. So the purpose of today's webinar is to discuss the ways in which current threats to language access are really putting patient-centeredness at risk. And we've titled the presentation Reclaiming Language Access because we believe that the same intentionality and vigor that has gone into establishing language access for healthcare also needs to be challenged to maintain it in times of inordinate stress to the system. Our project is based on conversations with Spanish-speaking patients and their families throughout the state of Ohio. Funded by a Eugene Washington Engagement Award from the Patient-Centered Outcomes Research Institute, our team sought to tease out a better understanding of patient perspectives on language access in Ohio, while at the same time reclaiming the voice of those served in order to better grasp their needs, wants, and expectations for language access in healthcare. Before hearing from our panelists, I'd like to invite Carmine to briefly describe some of the transformations in healthcare that have been caused by the current COVID-19 pandemic. Carmine?
Thank you, Glenn. The COVID-19 pandemic is ushering in unprecedented transformations in healthcare delivery. While increased demand and deferral of elective procedures will put significant pressure on healthcare systems, the spike in telehealth facilitated by expansion in reimbursable codes will alleviate some of that pressure. Additional, telehealth support such as virtual assistants, AI-based diagnostic, risk assessment, and mHealth messaging and tracking will also see greater penetration into the system. Medical interpreters have seen an abrupt shift to remote modalities with the result of in-person interpreters experiencing layoffs and furloughs in a time when their services are needed more than ever. At the same time, hospitals that were not set up to offer remote services before the pandemic have been forced into a position where language access is put off to the side, crowded out by what appears to be more pressing critical care concerns. COVID-19 is threatening language access at an accelerated pace. In this conversation, we seek to highlight the ways in which COVID-19 is upending language access services in different ways, while at the same time exposing ongoing health disparities.
Thank you, Carmine. So the pandemic crisis has really sharpened our perception of social inequities affecting multilingual and transnational communities. So let's get started with you, Parizad, as your work helps us to understand how the patient's individual experience is sort of a microcosm of these broader social forces.
Thanks, Glenn. Yes, it certainly has sharpened it because the unprecedented acceleration of the phenomenon of immigration and the large displacement of populations at the close of the 20th and the beginning of the 21st centuries have really made it implausible today to think of nation in terms of Benedict Anderson's utopian imagined community. The facts are that displacement and the back and forth movement of populations have resulted in the transnationalization and deterritorialization of culture and language on a global scale. And the United States has become increasingly a site for the presence of internal marginalized groups whose social cultural practices have been severed from their places of origin and whose experiences as displaced minorities differ significantly from the official dominant ones. So I draw upon work from Mary Louise Pratt, a literary scholar of post-colonial discourse, who posits her contact hermeneutics as a vehicle for addressing the bleaching out of linguistic hierarchy, social differentiation, and power asymmetry that Anderson's model disregards. Pratt's contact zones are heterogeneous and contested territories, much like border areas, where people from separate geographical, linguistic, and cultural locations meet, clash, and grapple with each other, often in the context of asymmetrical power. Within the domain of language, the notion of contact zone can reveal the extent to which dominant and dominated groups are not comprehensible apart from each other, and the extent to which their speech practices are organized by their difference and their hierarchy. So, framed in a medical context, Pratt's contact perspective allows for that clear understanding of how signification works across the uneven territories of linguistic difference and cultural misunderstanding in those in-between spaces where providers, supporting professionals, and their patients may potentially clash. It allows us to readily distinguish cooperation from coercion, compliance, or more complex responses within the medical encounter, rather than simply considering whether the practitioner's medical objective was met.
So contact zone is a really powerful lens for critically analyzing the patient's experience. How is this lens shaping your work with community partners in Ohio?
Well, in the context of the perceptions shared by members of our Spanish-speaking patient focus groups in Ohio, I think that the notion of contact zone helps us trace this landscape of inequity, fear, dissatisfaction, and miscommunication through which they must navigate in their real-life clinical encounters, through their speech practices with language discordant healthcare providers and supporting staff. For example, one of the common views shared by many members of our Spanish-speaking patient groups was a lack of trust towards the US healthcare delivery system. They narrated stories of how clinicians sometimes did not physically examine patients or run tests, but rather would briefly record their complaint and send them back home. In one particular case, a mother brought her ill daughter into the pediatric hospital on 2 different occasions, and both times was sent home with a diagnosis of the flu. When she returned for the 3rd time 5 days later, the healthcare provider attempted to send her home again without running tests, despite the fact that the mother repeatedly insisted that the child's condition had worsened significantly. In the end, frustrated and angry, the mother threatened to sue if they did not properly examine her child. The mother's firsthand knowledge of her child's complaints and the worsening symptoms at home were not deemed to be legitimate assessments of her sickness. There was no collaborative production of knowledge between the healthcare provider and the parent because the mother's knowledge system was simply not valorized. And it appeared from the mother's account that the offsite interpreter, who was participating remotely from a tablet screen, did not attempt to address, mitigate, or redress that inequity. Since the interpreter did not advocate for the mother's right to have the child examined, the traumatized Spanish-speaking mother found herself alone in this role. And in the end, the tests that she had demanded confirmed her fears and revealed that her daughter, in fact, had pneumonia.
So these stories illustrate, I think, in a powerful and even painful way, how Spanish-speaking community members are actively seeking this contact with their medical practitioners. As in the case of the family that endeavored 3 times to get properly diagnosed. So what are you learning about the factors that can fortify contact zones in a positive way? Is there a way that we can engineer more equitable contact zones a priori?
Well, yeah, I think so. I mean, these are dangerous sources of bias. For example, bias about one's own medical authority or bias about whether that knowledge needs to be comprehended in English that need to be named and interrogated. Our focus group members shared similar experiences of exchanges that conveyed biases on the part of providers and interpreters towards the patient's personal knowledge system. One patient was told that her pain was all in her head, and another was coerced by her interpreter into changing her pain level from a 10 to an 8. Members of focus groups repeatedly expressed concerns that their insufficient knowledge of English was the cause of the inequities in the treatment they were receiving. Suppressing and even silencing their own speech appeared to be common discursive practices for patients facing fear or intimidation during their medical encounter. So unfortunately, these sample experiences and perceptions underscore the fact that the US healthcare delivery is a linguistically and culturally contested social territory, fraught with interactions that often have deleterious impact on Ohio's Spanish-speaking patients' access to quality health and their feelings about themselves and their identities as Spanish speakers. Communication across this conflictive interactional divide can generate reactions of rage, fear, and intimidation that can express themselves through threats, compliance, coercion, suppression, and silence, as captured so acutely in this patient's quotation. So it's easy to feel demoralized about the entrenchment of such inequities, but I think that there are ways to move forward, and there are reasons to hope. Pratt herself argues that while the contact zone can be a dangerous territory for minorities, it can also be reconceptualized as a space of co-presence and meaning when borders are placed in effect at the center of concern, while homogeneous centers move to the margins. My experience with this PCORI project has underscored for me that in a clinical setting, border areas can in fact be meaningful bridge building spaces. Positive engagement can take place if there's institutional accountability and the healthcare delivery system recognizes and models the principles of cultural humility rather than those of cultural competence, in an effective content-based notion that often leads to paternalistic stances and stereotyping. Cultural humility, on the other hand, requires healthcare providers and their support staff to be lifelong learners of a process that involves really stepping outside of their own linguistic and cultural reference system and being true advocates for their patients. In the medical encounter, interpreters and social workers trained in cultural humility can play key roles as compassionate border crossers and multi-layered mediators or linguistic and cultural brokers. I believe that through changes in medical education, training, and in hospital health policy, US practitioners can also become border crossers by questioning their own cultural assumptions, repositioning themselves humbly in the margins as lifelong learners of cultural difference, and placing their patients in the center of the medical encounter as experts of their own intersectional cultural identities.
So do you think that harnessing this cultural humility is still possible even during the current crisis?
I don't think we have a choice. I mean, there's a sense that the healthcare system primarily needs to do what they're trained to do, right? To diagnose and treat. And then at some future time, maybe we can reflect on our principles of cultural humility. I have a hard time accepting that timeline. The decentering becomes increasingly urgent today in the context of COVID-19, since the crisis has exposed the increased degree of vulnerability suffered by members of Spanish-speaking communities who already carry a high-risk burden with conditions such as diabetes, obesity, and hypertension. Across the nation, minorities who make up a high percentage of the frontline essential workforce are being disproportionately affected by the pandemic. Members of vulnerable communities are less likely to seek healthcare because they do not trust the healthcare delivery system. They're afraid to make themselves known, and they fear that their knowledge and their cultural practices will not be respected. So in a time when there's even less access to daily changing information, to technology, to limited resources and care, our Spanish-speaking patients depend on intercultural health practices that value their varied systems of knowledge. These patients need access to trained healthcare workers who they can trust, to be their advocates and who will respond compassionately to their prevention and care needs without cultural prejudice. Today's COVID-19 crisis calls for open-minded and humble healthcare workers who will not only respond collaboratively to the needs of vulnerable communities as bridge builders within the USA contact zone, but who can also be cultural mediators and border crossers as they engage transnationally in the sharing of knowledge with global healthcare delivery systems.
Thank you so much, Perzad. So this COVID-19 public health crisis has brought many of the health disparities issues we've been confronting for years in much sharper relief. Racial, ethnic, and linguistic factors seem to affect rates of testing, rates of infection, and even mortality rates. So how do cultural factors within these groups impact and intersect with the experience of health disparities? And to answer this kind of question, I'd like to turn to Dalia Magana. Dalia, what is your research telling us about cultural factors?
Hi, yes, thank you, Glenn. In our study with Ohio participants, we found that gender and cultural norms affect barriers to communication in healthcare, but not in ways that past research might suggest. Past research shows that Latino communities may have the expectation that women will be passive or submissive, what is called Marianismo. Descriptions of Marianismo indicate that Latinas will suffer in silence, have a lack of agency or voice, and be timid. Marianismo may explain why some Latinas depend on their partners to make healthcare decisions. For example, it may explain their lower rates of cervical cancer screening. However, the women in our study challenged the concept of Marianismo in several ways. First, twice as many women participated in the focus group than men. We believe they participated in order to voice their issues and claim agency. Second, during the focus groups, women spoke proportionately more than men. While women represented 66% of participants, they spoke 82% of the time.
So what might these differences in participation tell us about the sort of ecology of health communication within Spanish-speaking families?
Yes, men's low participation in the focus groups uncovers an insight about the ecology of health communication in Spanish-speaking families. Our team tried to encourage the men to speak about their experiences, but we were not very successful. A few of the men shared that they did not have any communication issues. Some said that their wives or children dealt with all communication aspects of healthcare. When you, Glenn, asked the group whether they had other experiences with language access, a male participant said, "Problema? No." His wife, who was sitting next to him, laughed. She explained, "Porque yo soy la que me entiendo con todo lo de él." This quote is interesting because it underscores the struggle the healthcare system poses on their communication. In one case, a man acknowledged that he speaks English better than his wife, yet he still relied on her. Women shared that in their families, it was their job to communicate with healthcare providers. They generally found this very stressful. An older Puerto Rican woman described such a stressful situation. She says she does not speak English, and it took her 3 hours to obtain medication for her husband. Her husband healthcare providers miscommunicated with the pharmacy, and it was difficult for her to address the issue. She said that her area has few pharmacists and that service was poor overall, which complicates having access to a Spanish-speaking pharmacist. In another case, a doctor overseeing an emergency C-section told the participant that she would have to interpret for her sister, who spoke no English. The baby was 3 months early, and the doctors had said that the baby's chance of survival was only 50%. The participant said she was scared and shaking at her sister's bedside during the procedure, but managed to serve as her interpreter. She told us this should never have happened. A hospital should always have an interpreter.
So there's a sort of leadership role that women assume when it comes to communicating with health professionals. Did you get any sense of how this ecological organization was evaluated within the family and what implications that might have for our understanding of the role of cultural values in health communication?
Yes, in terms of their ecological organization, the men and women in our study agreed that in their families, women's work of dealing with communication in healthcare is acknowledged and respected. This may have been part of the reasons Latinas were open to sharing their health stories and pointing to specific problems in healthcare communication. Their stories showed resilience, bravery, and strength. They were not passive victims. They could discuss their vulnerabilities and healthcare experiences openly with us. And their stories served to empower others. As a group, they built on each other's experiences. The Latinas in our study are advocates and because they're voicing healthcare concerns. Limited English skills of professionals cause them stress, but that does not make them passive, as Marianismo would indicate.
So what contributions are Spanish-speaking women making that are not immediately visible in healthcare communication? And how is this COVID-19 public health crisis making these contributions more visible, perhaps?
Yeah, given the structural inequalities that Latinos face and that the COVID-19 crisis exacerbates, interpreters as well as community advocates have an important role in conveying timely and accessible information to Spanish speakers. Latinos are a vulnerable group. They face health disparities such as high rates of HIV, AIDS, diabetes, COVID-19. They have lower income, lower levels of education, and less likely to have health insurance than the general population. They are unlikely to be in jobs that are essentially untouched by the need to work remotely. As a result, they're experiencing a high threat to their finances, to their health, and to their safety. Under such conditions, those who get sick need to speak with a provider who speaks their language. Language and cultural barriers worsen health outcomes and lower satisfaction with care. Spanish-speaking patients report better consultation experiences and show better health outcomes with Spanish-speaking providers. However, Spanish-speaking and Latino physicians in the US are severely underrepresented. At the same time, Spanish-speaking women are doing more than undertaking healthcare communication for their families. In the interpreting field, 75% of medical interpreters are women. These women are helping to save lives. Latinas are also playing a key role in grassroots level efforts to convey important information about COVID-19 safety and resources. Local Latinas are using social media to convey important information to Spanish speakers. For example, a health advocate in California's Central Valley, a medically underserved area where half of the population is Latino, created a Facebook page dedicated to sharing resources and information about COVID-19 in Spanish with locals. This page has 1,400 followers and offers the latest updates and advice about the virus, including webinars with health experts. It offers resources on everything from health and safety information about the virus to obtaining financial support. In our COVID-19 reality, Spanish-speaking women are taking on important roles and serving as advocates. We hope to have raised awareness about the important, yet many times invisible labor of Spanish-speaking women. Health advocacy has never been more important in our lives, and Latinas are leading the way in their families and communities.
Thank you, Dalia. I think it's so important to recognize and affirm these internal strengths that connect communities with vital information. Yet COVID-19 is upending traditional forms of healthcare delivery and leading to an explosion of telehealth services that's likely to stick around long after the pandemic is abated. With that in mind, we'd like to switch gears and consider patient perspectives on remote interpreting services in particular. Rachel, can you share a bit from your findings on this topic?
Sure. Hello, everyone. The current context of social distancing norms in hospitals inundated with patients suffering from illness caused by COVID-19 has led to an increased need for interpreters who can provide services over telephone or video conference from a remote location. This is called remote interpreting, and many of the patients we talked with in Ohio in 2019 had experienced difficulties with this modality. I'm going to talk about what happens to the social relationships in the provider-patient-interpreter triad when the interpreter is not physically present in the room. In this case, we believe that the physical distance can actually lead to literal social distancing. So let's talk about the different ways that language access is provided. The ideal way to provide language access in a healthcare context is physician-language concordance, when the physician is able to communicate proficiently with the patient in their preferred language. But unfortunately, language concordance is not always possible, and the alternative is for an interpreter to provide language access. When qualified in-person interpreters are not available, clinics and hospitals can contract with companies that provide remote interpreting services via either telephone or tablet. Here's what video remote interpreting looks like. Remote interpreting can also be used for information call lines and telemedicine, which is being utilized more than ever during the COVID-19 pandemic. By the end of March 2020, telehealth programs were reporting anywhere from 70% to 158% increases in use.
So, Rachel, you're raising some critical issues about whether healthcare systems already had remote interpretation systems set up in place prior to COVID-19. And I'm sure you'll circle back to this later. But I'm wondering if you can help listeners, especially those who have not experienced interpretation, remote interpretation firsthand, imagine what this dynamic is like.
Sure. Here's one way to think about it. Think about a time you've used Skype or Zoom to have an important conversation with one or more people who you didn't know well. Did you feel nervous or uncomfortable? Did you think that the modality of the video conference might have made that conversation different from the way it would be if it were an in-person meeting? Maybe you couldn't see all the people you were talking to and you couldn't see all their body language. Maybe your future career seemed to depend on that conversation going well. So what if it was the health of your child that required a doctor's comprehension of their symptoms? Video interpreting creates a layer of separation between the patient and the other people in the conversation that could potentially have a negative impact on the outcome of care in some scenarios.
So in your work, even before the COVID-19 outbreak, you've been talking to community members in both Ohio and Kansas to better understand how language barriers affect Spanish speakers' experiences with healthcare. So what are patients you've spoken to saying about remote interpreting particularly?
Well, the patients we talked with in Ohio expressed that the use of remote interpreters limited the conveying of emotions, impeded the interpretation of other conversations in the room, for example, between providers, led to less negotiation of meaning, and that sometimes it was difficult to hear what the remote interpreter was saying. And one thing that we found striking in the way that the patients talked about remote interpreters was that they never referred to them as people. Instead, they used the term la máquina, the machine. Here's how one patient addressed interpersonal communication with in-person interpreting versus when using la máquina. The patient said, sí, aparte que uno se comunica lo que está pasando, mientras los doctores conversan, uno puede intercambiar algo más, aportar algo más con el intérprete. Y con una máquina no se puede. This patient seems to be referring to the possibility of making a personal connection with an in-person interpreter. Note that they use the term máquina to refer to the remote interpreting service, even though there is an actual person doing the interpreting. It seems that the technology is causing a person, the interpreter, to be perceived as a machine, which may indicate how patients feel about the type of interaction that takes place. In a sense, the patients dehumanize the interpreter by referring to them as a machine. It's important to also mention here that published research in the field of healthcare has suggested actually using machines to interpret, which I think will automatically raise a red flag for all of us as applied linguists, perhaps leading us to imagine a post-humanist dystopia. But we think of language and interaction in a much more nuanced way than many scholars in public health. And so some of the questions that we ask may not be covered in that field. An object can perhaps interpolate with a human. I mean, my Fitbit talks to me all the time, but I don't know how a machine would be able to serve as a clarifier, a cultural broker, and an advocate for the patient, which are all important components of the interpreter role, and even less inspire the patient's trust. Remote interpreters are not machines, but the remote interpreting device complicates interpersonal communication by adding a level of distance. It limits the possibilities for using nonverbal semiotic resources and for perception of physical positioning. One of our concerns about this is that it may impede the negotiation of common ground between the patient and the provider, which could affect the patient's response to information and directions.
Can we talk about these uncertainties and limitations a bit more? As you try to wrap your head around the potentialities of La Máquina, what do you worry about as an applied linguist during the COVID-19 outbreak?
Well, as we have all experienced, the pandemic has hurtled us into an era of increased dependence on technology in our communication, further complicating the challenges of providing equitable care for those with language access needs. Remote interpreting is being used now more than ever because in-person interpreters are now often not allowed in exam rooms. Other potential barriers to understanding in the COVID-19 context also complicate the picture. These include patients wearing masks, the noise of ventilators, patient difficulty speaking due to respiratory problems and treatments, and the absence of family members during hospital care. In addition, large numbers of interpreters had to make a sudden switch to the remote modality before new accelerated training programs could be provided. The situation is further complicated by the increased use of telehealth and the technology needed to provide professional interpreting services for this modality of healthcare. There are video remote interpreting systems that can be built into a telemedicine platform, but these were not necessarily in place before the pandemic. Now, some providers I've spoken with recently in Kansas are not utilizing this technology when providing telehealth services to their patients who need language assistance. An understanding of the challenges of remote interpreting and how to overcome them are now more important than ever. It is imperative that we develop a more profound understanding of the ways in which remote interpreting affects communication in healthcare contexts. The lives of many individuals may depend on our ability to facilitate communication in this unique type of interaction.
Thank you so much, Rachel. Your last point accentuates broader concerns about the telehealth infrastructure of our healthcare system. I imagine our audience may have questions that we can address later during our Q&A session. We'll now turn to Carol Harden, who will shift our attention to health literacy, one of the principal causes of health disparities in health information and health outcomes among language minorities. So Carol, how do you think the current COVID-19 public health crisis is both informing and transforming our understanding and appreciation of the role of health literacy?
Well, studies on doctor-patient communication underscore the importance of both medical core competencies and health literacy. In the era of coronavirus, these are even more important because information is changing quickly. And control of information is different because this is an evolving emergency, an outbreak versus emergent information about a known illness. Because it's a public emergency, there's a need to control and appropriately disseminate information, even more so for speakers of languages other than English.
Can you help us to distinguish these two concepts, core competency on the one hand and health literacy on the other?
Sure. For US doctors, there are core competencies that form an integral component of medical education. And these competencies include patient care, medical knowledge, practice-based learning and improvement, interpersonal communication skills, professionalism, and systems-based practice. Each area includes a patient-oriented aspect. In contrast, health literacy is often used to describe patients. It includes both capacity and skills, the capacity to make informed health decisions and the skills to make sense of information and services and provide these to others. It's a complicated construct involving individual, societal, and systemic factors that are situated in social practice. The problem is that despite its recognized importance, health literacy is generally placed on patients rather than on healthcare providers. So patients' low literacy is seen as deficient, even though providers also lack crucial knowledge related to patients and their healthcare. Spanish-speaking patient reports about their healthcare experiences illustrate the relationship between competence and health literacy. Patients' observations differed from prevailing medical definitions, revealing systemic effects on medical care due to language barriers. Patient perspectives expand the concept of health literacy, reframing it as partially a lack of provider-side insight into the illness experience. And these problems are further magnified during COVID-19 at a time when clarity is essential.
So it seems like context and expectations are key, both in enacting and in deciphering these core competencies. How do these two factors emerge in communication?
Two concepts, schemas and frames, can be helpful when examining doctor-patient communication. Tannen and Wallet describe schemas as expectations in interactions. The differing expectations between doctors and patients have been described as different territories of knowledge, the voice of medicine versus the voice of the life world, or epistemic divergence. Divergent knowledge schemas help explain the mismatch of understanding medical interactions. And according to Gottman, a frame defines a situation or a social activity a person creates. So shifting frames provide a basis for understanding talk, and frame incongruity can create misunderstanding. The primary issue related to competence that each patient group identified was the lack of providers who speak Spanish. Patients framed interpretation as, quote, a lottery. Patients identified systemic barriers and linguistic obstacles, referring to repeatedly being passed back and forth like a ping pong ball. Patients also emphasized times when they felt silenced by providers and interpreters and were not allowed to explain their situation. In the current crisis, monolingual Spanish speakers are effectively silenced when public health communication takes place in English. And also, as Perazad previously noted, patients framed discriminatory treatment as an issue related to competence. In the medical world, health literacy is viewed as a problem on the patient side. And so, adding to what you see on the slide right now, we also heard patients talk about bearing the burden of trying to improve communication, in their words, by trying to learn English. But they also talked about not showing up or giving up rather than trying to explain to someone who won't listen. They described doing the best they could with limited information, and their comments suggest a frame of agency or involvement in their own health care. Patients described how they complained, refused care, or took family members along as linguistic brokers and advocates. They also validated an aspect of their health literacy through their flexibility and patience with the healthcare system, as shown here in number 4. The patients don't have time right now to be flexible and patient with the system. There's an urgency for trustworthy communication in Spanish that's magnified right now. So in sum, the perspective is flipped. Patients view healthcare personnel as lacking competence because providers don't have access to Spanish language abilities, and they do not necessarily understand patients' experiences. In contrast, patients may see themselves as not having the possibility of access to health literacy. So for example, patients may struggle to wade through the flood of written information on COVID-19. Even highly skilled readers are overwhelmed right now. With so much information on the web, conflicting guidelines, and circulating myths, Spanish speakers with limited digital skills or internet access have the added burden of finding information that makes sense to them. These challenges are not about an inability to read and speak English. For patients, language is a social interaction, not just a tool to translate a message. This is crucial during coronavirus because patients are more likely to find information from sources where they already have a relationship. Whereas physicians frame education as a means to patient health literacy, patients frame insight into the illness experience as being necessary for provider competence. In other words, patient perspectives reframe competency and health literacy as something required by both sides.
So there's a sort of dialogical relationship between competencies and literacies. How do you think applied linguists can help to characterize and further advance our understanding of this dialogic relationship?
Well, applied linguistics offers a tool to both understand and advance health literacy, and applied linguists can provide an explanatory analysis for how patient experiences inform their beliefs and therefore their outcomes. We can analyze the reality of what patients actually say and describe what they actually do. Our research suggests a need for more interprofessional collaboration between healthcare and language professions to better assist Spanish-speaking patients in navigating a linguistically taxing system. Medical professionals and public health advocates need to continue efforts to clarify and simplify the system for speakers of other languages so that patient competence is actually possible. Communication at each step, government programs, insurance, clinic reception, laboratory, pharmacy, interpreters, written information, and doctors can provide patients with access to competence. Linguists and health communication specialists can further provide what Raymond calls epistemic brokering, to work towards common ground in interactions between patients and healthcare personnel. And although Raymond applied the term to interpreters, other language specialists can also help broker knowledge between the patient side and doctor side to help healthcare personnel expand their own health literacy and more meaningfully communicate with Spanish-speaking patients. Unfortunately, health establishments do not necessarily know the ways that patients access information. So what are some action steps related to COVID-19? Just as an example, where I live in Texas, a central repository has been formed by a community leader so that Spanish speakers can access credible information for a variety of needs. Spanish professors have worked to quickly translate testing protocols for clinics, and a series of videos have been posted on social media with a Latina doctor who speaks professional Spanish offering up-to-date information. We still need good interpretation in Spanish during live news, and education, finance, and religious institutions could also provide communication related to COVID-19 in Spanish. Finally, we can create an asset map to take inventory of our community strengths and resources and help uncover linguistic solutions to improve healthcare.
Thank you, Carol, for those insights. I really appreciate the emphasis placed in your closing remarks on our role and responsibilities as applied linguists, highlighting how our tools for studying language identity and language use are really central to the study of the multilingual patient experience. Health disparities affecting Latino communities are really sobering, but I agree with you that the work of applied and Hispanic linguistics are really a source of hope. So Marisol, could I ask you to offer some thoughts and then get us started with the questions from the audience?
Yes, thank you, Glenn, and thank you to all of today's panelists. If you're looking at the Q&A, it's exploding with questions about remote interpretation specifically. And if that is an indication of the intentionality and vigor that the webinar attendees are bringing to this discussion of language access, I can't think of a better metric. Glenn, I just want to offer a few thoughts and harken back to something you said at the start of the webinar about bringing intentionality and vigor to the work of preserving language access, particularly during these times of inordinate stress. Many of us on the call probably have heard Dr. Anthony Fauci make a similar point about health disparities in this country. And I'm paraphrasing him here. He said something to the effect of, we need to rigorously continue to protect the most vulnerable, even as we begin to relax public health guidelines. In other words, we can't afford to let up our efforts to protect the most vulnerable. I think many of you are already in the domain of health disparities, but if the work of language access and health disparities is new to you, I think today's webinar offers you a great resource that you can pass on to colleagues of ways that we as applied linguists can act with that intentionality and vigor that Glenn is talking about, so that we feel we are part of the inertia that's protecting the most vulnerable in our Latino patient communities. I think another lesson I'm learning, and the Q&A again is testimony to this, that working to mitigate or eliminate these language barriers is of course essential work, but that in and of itself will not promote a culture of patient-centeredness in healthcare. The promise of patient-centeredness for US Latino communities requires that we redraw the lines of authority in healthcare, unsettle our assumptions about patient-provider reactions, and the learning of new communication patterns that involve AI and digital platforms. I just want to say very quickly, I read something in our Q&A that sort of made me stop. One of our attendees talked about an experience where the patient told her something when the provider was out of the room. The provider came into the room. She turned to the doctor and said, "I would like to tell you what he just told me when you were not here." And that, in fact, upset the doctor. My point here is not to vilify the medical practitioner. I think we're all trying to do the best and right thing. But if that example tells me that we need to be studying interaction much more closely in these multimodal environments and not view these digital platforms as a resolution to some of the inequities that we're concerned with even before COVID hit. I also want to acknowledge that there have been comments in the Q&A about it's not just applied linguists, that there are other people doing work in this space, and I agree. We must not delude ourselves into thinking that applied linguists have the answers here, although I would say that we are not at the table as much as we should be. And it is opportunities like the grant that is funding the panelists today that makes, that is remarkable, because it is not often that our concerns as studiers of interaction are funded. So we can come back to that probably at a future point, but Carol has reminded me that there are many practitioners working in other areas, schools, libraries, clinics, medical training programs. I think you're on our call today, which indicates no one discipline owns this language access issue. I think we've painted somewhat of a bleak picture that many of us have experienced even firsthand in our work, that talk about the gap that we're trying to close here with this focus on patient-centeredness. If I could just get the slide with the quotation from Carol. Carol, could I ask you whether you could read in either language? You didn't get a chance to read this one, and I just wanted to highlight this. Could you read that for us?
Sure. Que tampoco yo la voy a culpar a la señora. O sea, a lo mejor yo también, no solamente ella. Aquí yo estoy en este país, que yo sé que cualquier persona que te sirva es mucho, porque nosotros, pues, para empezar, somos indocumentados. Yo sí estoy muy agradecida con las personas porque así como me han tratado mal, muchas me han tratado bien también.
Thank you so much, Carol. I bring this up, again, the goal here is not to vilify our healthcare system, but to look at the patient experience here, to go into a situation and expect to be treated not well. It goes to the heart of what brings us together here. We found other examples of that in today's webinar presentations. Rachel's discussion of the patient's view of la máquina suggests that technology has hardly supplanted the need for human empathy and relationship. In fact, I think we're all realizing that technology has made that trust piece even more critical for multilingual populations. There is hope, and we heard stories of hope today. I hope you feel the same courage that we heard in Parizad's presentation, where we learned of a Latina mother who refused to give up her quest for healthcare and took 3 trips to a pediatrician's office before she was able to convince them that her daughter needed to be diagnosed for pneumonia. And in Dalia's presentation, we heard many voices of Latinas, wives, mothers, health advocates, frontline healthcare workers that truly showcase what Bourdieu has described in our field as the power to impose reception on others. The organization that Glenn mentioned at the start of this presentation, this webinar, is PCORI. You see it at the bottom of the slide, Patient-Centered Outcomes Research Institute. We encourage you to check out their website for all of its resources. But I want to draw attention to a question that goes up to the heart of their research priorities. And the question is this: given my personal characteristics, conditions, and preferences, what should I expect will happen to me? During this pandemic, when no one is considered immune, we know what it would be like to be a COVID patient. And so this question has a pressing pulse on all of our lives. Given who I am, what should I expect will happen to me as a COVID-19 patient? How would you want to be treated by your healthcare system? If anybody on this webinar has been affected by COVID-19 or directly or somebody you care for, first off, we want to express that we hope that everyone is on a path to strong recovery. And we also invite you to add questions and comments to our chat line or to our Q&A line, because your experience certainly has an education for all of us. I'm going to transition to our Q&A segment. And as you can see, there's no way in our remaining time we're going to be able to answer all of those wonderful comments and questions that have come in. But I'm going to jumpstart it this way. Tatiana, if you could give me a time check just on how far we are from our closing. Tatiana? Oh, okay, thank you. So she tells me you have about half an hour, which is perfect. This is going better than most of my lesson plans. So let's begin. I'm going to throw out the first question, seeing that it sounds like we have a critical mass of people who are curious about not only the Spanish language, but also how both Spanish and English are being used in our healthcare system. And I wanted to ask a question of our panelists to share insights on words and expressions in Spanish. And if attendees have one too, they can throw it in the Q&A box. Language in Spanish that you feel are central to our understanding of what patient-centeredness means in Latino communities. I'm going to cite the work of Valenzuela, who gave us this concept of cariño to talk about the kinds of relationships that support children in K-12 minority education, and how that concept helped to really change the way we think about what caring educational environments look like. I'd like to open it up to our panelists. Parizad, could I begin with you? Are there expressions or words in Spanish that we could use as a starting glossary of the way we imagine patient-centeredness should be defined in Spanish?
That's an interesting question, Maricel. Thanks for that. I think if we look at, for instance, the term compassion in English and its counterpart in Spanish, compasión, right? Mm-hmm. So they're actually not perfect cognates. In English, compassion has that sort of sense of empathy, of equality, while compassion in Spanish has a slight paternalistic nuance to its meaning. So, sentir compasión por los pobres, sentir compasión por los desafortunados. Mm-hmm. The one who feels compasión positions himself or herself in a place of superiority. Whereas in the English sense, it's more of empathy. It's more of a relationship of equality.
Yeah, thank you. That's such a wonderful example. Dalia, Rachel, Carol, would you like to add to this?
Yeah, I'll be happy to add to this and say a couple words about confianza, which is something that participants in the Ohio study, but also people that I've spoken to in California yearn for in the medical setting. And one of the reasons is that there's a lot of mistrust in Latino communities when they go into a healthcare setting. And it is a vulnerable space for all, but even more vulnerable when you face certain barriers like language, cultural barriers, but also in a society that discriminates against certain groups. So confianza is important, and it means trust and intimacy. It also overlaps with another cultural construct of personalismo, which is where Latinos prioritize building an interpersonal relationship before an institutional one. So these two concepts can help overcome some of the mistrust that Latinos face.
Thank you for that. You're echoing some comments earlier about how remote interpretation telehealth platforms are more effective when people know each other. And so thinking about it as a condition for building patient-centered dynamics. Carol or Rachel, did you want to add to that before we move on to a new question?
Mine is probably more minor, but even going back to the very basics, if you think about the word enfermedad, illness is not necessarily also, it overlaps with disease, but there's no distinction. Whereas in English, we make this clear distinction. And I think that that's an important, just foundational concept.
That's wonderful. Rachel, I know you've talked about confianza before. Are there other phrases you'd want to bring our attention to?
That was the main phrase that I was thinking about, or word that I was thinking about for this discussion.
I also think that you've definitely given me a pause to think about la máquina and whether that is pejorative or positive sounding and for which patient populations. And I think that's a great way to segue to questions that have been coming up. Carmine or Glenn, we've had lots of questions coming up about, well, what do we expect of interpreters in this current climate, particularly with telehealth and remote interpretation? What are they expected to do? And so I would say that questions came in one of two areas. There were, what are the qualifications? What are the requirements? What do we expect to do? Which is a definite nod to the class standards. And then a lot of rich commentary about actual practices. How do you set it up? How much do the patients know each other, or the patient and the provider know each other and the interpreter know each other? What should you do beforehand? Should the interpreter correct? How do you do that politely and professionally? I mean, these are certainly questions for training, but I think people are also asking about what are our expectations from a patient-centeredness view? Carmine or Glenn?
Yeah, so really the standards for video remote interpreting are really just coming into their own. And they've typically relied on the face-to-face interpreting established standards and protocols. Telephonic interpreting has their own standards. So I can give you one example of that. So in face-to-face interpreting, the interpreter reserves for themselves the third person and uses the first person and second person for the interlocutors. So if the doctor says, have you been feeling better? The interpretation is, ha estado usted sintiéndose mejor, right? So the second person is used for the two interlocutors and not the interpreter. If the interpreter has something to say, they'll say the interpreter would like to interject, right? So using the third person for themselves. In telephonic interpreting, that has traditionally not been the case. So telephonic interpreters are trained not to interpret in the first person, but rather to say, he's asking if you would, if you've been feeling better, right? Rather than, are you feeling better? So that's one clear difference in telephonic and face-to-face. But I think that there really is a lot of work to be done in terms of developing those standards for specifically video remote.
Yes.
And some of the colleagues on our team are working on that. So some of Rachel's slides showed Marty, which is a remote interpreting company, and they're kind of working on developing sort of standards for video remote interpreting, which I think is becoming more and more common these days.
Thank you, Glenn. Go ahead, Rachel.
Yeah, the questions about remote interpreting and the issue of patients needing to feel a sense of confianza. This was also something that came up a lot in the discussions in Kansas, that patients often felt in an in-person or remote context that healthcare providers felt cortante, dry or terse in these interactions, interpreted interactions or interactions directly with the healthcare providers. And I think it has to do with an expectation that we may not be addressing with the current the current guidelines for codes of ethics for interpreting from U.S. institutions. We may need to re-examine the notion of professionalism and how we are interpreting that. This focus on fidelity, which was one of the questions that came up. Somebody asked, how can we allow the Latino patients to feel comfortable when we have to be so focused on exact interpretation, fidelity of the interpretation. And I think that there are other ethical principles that need to be taken into consideration. I think that a reevaluation is needed. And this is something it's starting to be discussed in the literature.
Yeah, I would definitely say that the current standards for, standards of practice for interpreting are not necessarily completely aligned with our notions of patient-centeredness. And PCORI, I think, as a funder, has a real role to play in that kind of, questioning and reevaluation that Rachel's talking about.
There's a question about whether you guys specifically are involved in that kind of articulation process. How would someone get involved in that process if you wanted to look at the alignment of patient-centeredness in current class standards? Is there a meaningful route to get involved, Glenn?
Yeah, certainly. I think the more research and us bringing these different kinds of questions from different aspects, both interpreters and applied linguists and cultural studies scholars, I think there really are just a lot of opportunities to bring that to the fore, both through funders like PCORI as well as through the NIH, and particularly the National Institute for Minority Health and Health Disparities are very interested in these questions right now.
I think the format that we've been using of the stakeholder meetings, which is something that's strongly supported by PCORI, is it's a very powerful way to address these kinds of questions, allowing people to share their experiences, facilitating communication, interaction, and sharing of experiences and perspectives between patients, interpreters, healthcare providers, patients' family members. I think this is a very important process for our communities and our interpreters. I think there was also a question about interpreters. What can interpreters do? And that's also something that we've been addressing in our stakeholder meetings in Kansas. And I think that's a really important point. What can interpreters do to raise patients' awareness of their rights? And this is something that you can organize in your own community. And it's something that we've been discussing in Wichita, organizing a group of interpreters who are part of our stakeholder team, who will be able to present information about interpreting codes of ethics and patients' rights and how it all works to the groups of patients that we're working with. Mm-hmm.
Thank you, Rachel. I think your answer about the role of the community for their input and their decision-making is important. I think that will help us think about a question Luis Marentes asked us at the beginning of
Before we go into that, Marathon, I think it would be good to kind of point out the philosophy of PCORI before we continue, just so everyone's kind of on the same.
Okay. Yeah.
So,
yes.
Rachel's talking about these stakeholder groups, and the approach that PCORI has taken to health research is very different from the approach in the NIH and other large, funders of health research. And it's different because PCORI is interested in research that will be taken up and that's important to patients, right? And what that sort of translates into is that patients are involved in every process of, in every aspect of the research process. Patients are involved in formulating questions. Patients are involved in designing and developing a study design. Patients are involved in collecting data. Patients are involved in interpreting data. Patients are involved in dissemination, right? So, every aspect of research has significant patient involvement and engagement. And the idea is that if that's done, then patients are much more likely to take up the results of that research in meaningful ways that affect their experience within the healthcare system.
And that's useful. I think we'll definitely make sure that the PCORI website is made available to you, and we can even recommend resources to help you get started in this discussion. I wanted to direct attention to a question that came in earlier from Luis Marentes. What is the role for students and their families who do not necessarily have credentials, but in the pandemic and in really all times of healthcare could be important interpreters and translators? And I think that builds on Glenn's points. If it really is a patient-driven process, what are the other people in the patient's network? And there's an uneasiness around using ad hoc, untrained interpreters with using people who already have lines of established trust with the patient. And I think we're struggling to figure out how to regulate or monitor and even acknowledge promising practices. Dalia or Carmine, could I get you to comment on either one of those, given your work in the community?
Sure, I'll be happy to answer the role of family in healthcare settings. I think it's very important to work together with families. And there's also another cultural construct of familismo, which means the family is a center. So for many times, a Spanish monolingual going into a consultation room, they might feel more comfortable if there's a family member there with them. That family member has intimate cultural knowledge that could help advocate for the patient. That family member might be able to bridge literacy gaps, for example, filling out paperwork or information that's being conveyed to them. So this is a big task, this labor that immigrant children do, but it's important to recognize that labor. It's also needed to best advocate for patients.
I think another very important point here is that during the COVID crisis, we are increasingly using a lot of digital resources, and the role of other family members are highly important to bridge that gap at times. Older generations not being familiarized with digital resources can also cause some stress in the family.
Thank you so much. I'm wondering if we can turn to the provider training piece, as that is an area of expertise that our panelists do share. Thinking about how to bring the focus on patient-centeredness early on into formal provider trainings, but also your ideas about how to, I think Parizad, you've used the word inject these ideas about cultural humility, context zone, cultural competence, confianza into in-service practice, and what are meaningful opportunities to do so. Parizad or Carol, could you start us on that discussion line?
So part of that piece on cultural humility is that it is a lifelong, right, ongoing process. And so there's no mastery of content, but that you're constantly learning and reevaluating your own biases and prejudices, and learning from your patients and what they say about who they are and their multi-dimensional identity. So I think that it is really important to start early with that kind of training. Work has to be done. We've heard from the presentations today and through the experiences and perceptions shared by our patient group that there's a lot of work that needs to be done, and it has to start early in practitioner formation. I mean, ideally in high school, but for example, here at the University of Akron, at the undergraduate level, the Certificate of Advanced Spanish for the Health Professions integrates these principles of cultural humility directly into the certificate coursework and through community engagement. So in class, we sort of discuss about some of the issues and missteps that can occur during this kind of experiential learning in the Spanish-speaking community. And medical schools also need to recognize the importance of integrating this cultural training into their curriculum for their med students. Surprisingly, this kind of training is not typically offered from my experience with the med school, NeoMed in our area. And finally, and I think this is really important, the medical establishment, the hospitals need to constantly facilitate training in their continuing ed classes, but not only for their doctors and nurses, but also for their staff, right? I mean, every person that the patient comes into contact with from the minute they walk into the hospital or the clinic till they leave, because hospitals should be modeling these principles at the organization level. So studies have shown that organizational cultural humility provides that kind of environment, that kind of culture where administrators, doctors, nurses, and supporting staff interact with one another, horizontally, without hierarchies, with equity and respect. And I think that kind of modeling is essential.
Thank you so much. Carol, I'm wondering if you can also comment on promising practices for the actual teaching of Spanish.
Sure. Yeah. And I would say it even needs to be articulated and go even all the way down to dual immersion, starting earlier just with language policy in the United States. We need a better language policy, a prioritization of that, and it needs to be ongoing. But I would also say there's a lot of good efforts going on, but it's just some of it's evidence-based and some of it is just haphazard. And so it's a mixed bag. And many of you are probably aware of the Medical Spanish Task Force that's trying to standardize for medical schools what's being done there. But I would say a nuanced approach really needs to be used. And there's all kinds of ideas out there. Ideally, we want to get people to an advanced level if we can. And so with advanced speakers in undergrad, what we do is try and do some significant community involvement where they are significantly observing interpreters and bilingual professionals. And then they're going out after that portion of time and they're helping with health fairs, they're helping with wellness centers, they're working in that sort of thing to foster, they learn cultural humility as they make mistakes and observe.
That's both of those. I think between the two of you, you're giving us some curricular pillars to wrap our head around. Rachel, did you want to talk about your work with heritage language learners or how you work in the multimodal aspects of remote interpretation?
Well, I was going to add regarding the question about training that at Wichita State, we've been doing some interprofessional simulations, including interpreting students in healthcare simulations, patient care simulations that were already being done in the School of Nursing. And we've been working on finding ways to incorporate issues of cultural humility in these simulations as well. For example, having a patient who is interested in practicing certain cultural practices of healthcare that are different from the biomedical healthcare approach. And so that the patient and the interpreter, or the healthcare provider and the interpreter collaborate to communicate about that with the patient. And I think that this is also a really good opportunity for the provider, the healthcare profession students and the patient interpreting students to learn to collaborate together with each other. So was there something else that you?
No, that's fine. Sorry, I didn't want to interrupt, but I think you're also helping us think about interpreting not in a global sense, but interpreting around specific areas of health, or are we talking about preventive health, or are we talking emergency health? And we really even haven't gotten close to that level of nuance, but it certainly is telling me it's a starting point. But it also does make me think about, and Carmina, I'd like to ask you to comment from the healthcare perspective. We have a quarter of our participants who work in public health or healthcare and provide service. I often feel that we as applied linguists need to better understand the way our U.S. healthcare system works. For example, in my health literacy curricular work, I've had to teach myself how public and private insurance works in this country and who gets it, what kinds there are, how it differs by county and state. And I'm wondering if you can help us think about areas that we as applied linguists also need to be lifelong learnings about the way our system is organized, and even work with other collaborative partners. You brought up this point about how we need to rethink our coding in insurance systems so we can actually be properly reimbursed for telehealth services. Yes, an important point that I don't typically think about as an applied linguist that focuses on interaction. Other areas of healthcare that you think we should be paying attention to?
Well, I think that overall applied linguists are very well positioned, and they can contribute important social linguistic realities into the healthcare culture and communication as a whole. Specifically helping to illuminate the relationship between the disadvantages happening right now in COVID-19. And yes, there are some coding expanded now with COVID-19, and specifically for telehealth. It was very much needed. It still depends on state-by-state basis in the long run, but I do think that this is going to be a game changer in the healthcare system. And more than ever, I think applied linguists need to be able to have a position in the table and highlight this diversity in linguistics, racial, ethnic groups. But overall, I think that it's very premature to determine how this is going to change in the long term. I think we all have something to learn from this, but hopefully this can be something that can we can learn from, and also offer access to those that are cannot or is lacking in interpretation services. I do think that telehealth is going to stay here for good. I think that is going to be expanded. We're way behind compared to other countries, and given that we are a very diverse country, linguistically speaking, then we should be doing better about accessing those services.
Thank you so much. I'm going to ask as you talk about services, I'm going to ask a resource question in our final minutes, and then I'll turn it back to Glenn for concluding remarks. We've had a couple questions about recommended Spanish resources that you might want to share with the group. I'm sure we have more resources. We'll put that on the webinar website. And we also had a question about, do you have good videos for modeling promising practices? Is that something that webinar attendees can look for in this group of panelists?
I'll jump in here.
Thanks, Carol.
I think this is really an issue, the lack of availability of realistic, authentic videos and conversations, because I think there's a lot of videos out there that are didactic, but some of them are contrived or they're created. Maybe not necessarily, they aren't necessarily authentic. So I know a lot of us have our own personal videos that we've created, but I think that's really an issue that would be a wonderful, wonderful resource.
Other resources, there have been questions about, can I learn more about the class standards? Can I learn about remote interpretation certification? So we'll post that later. But if there's anything else to share now, if there's not, then Glenn, I'll pass it to you.
Okay. All right. Well, thank you very much, Marisol, and thank you to all of our panelists. I want to give a shout out to Tatiana as well and Sujan Mandanhar, who has been doing all the behind the scenes work here. And thank you to everyone who logged on. It was really very rich set of questions. We will get a transcript of those questions and go through those and hopefully be able to answer as many as we can. So there are a few ways we'll follow up after today's webinar. Shortly after this webinar, you'll get an email with a short evaluation. So if you can just fill that out, that would really help us, and we thank you in advance for the feedback. Sometime next week, you'll be able to access a recording of today's webinar at the website you see on your screen, the u.osu.edu/language access research. And we'll also include there a list of resources and references mentioned in the panelist presentation, so you'll have access to that as well. If the concept of patient-centeredness is new to you, we also invite you to check out the PCORI website, also featured on the slide. That's just simply pcori.org. Do we have a poll that we're going to put up at this point, Tatiana? There we go. So we'd like you just to answer this brief question about this webinar. So what next steps are you most inspired to take after this webinar? Attend more webinars like this, attend a workshop on language access research and patient-centeredness, apply for grant funding, get involved in advocacy work, volunteer to help multilingual communities. So let's take a minute to just go ahead and post your answers to that. Okay, can we see the results, Tatiana? There we go. Okay, so I'm seeing a lot of people want to attend more webinars like this and workshops. So given that our poll revealed those interests, our plan is to do some brainstorming within our own professional networks. For example, within the AAAL community, the American Association for Applied Linguistics, where actually we were scheduled to present this webinar as a colloquium at AAAL, which was canceled because of COVID-19, and other areas or other associations to see whether future professional webinars or networking events can be integrated into upcoming conferences. So please stay tuned and check our website regularly, at least within the next 3 to 4 weeks or so, and we'll be trying to communicate with you on other things that other ways that we might interact and move forward a bold and cohesive agenda for language access research, especially in these times. I think there's so much to be brought to the table by people with varied backgrounds like all of you who have attended today. So on behalf of the entire panel, I'd like to say thank you to Tatiana Friedman, to Carmine San Martin, Charlie Boss, who is our communication specialist, Sujan Mandahar, who is our technology specialist, for all the behind the scenes assistance and support for today's webinar. And I thank you again for attending, and best wishes for everyone to stay safe and healthy. Thank you.